Hi again, fit for dermoscopy and the new universe here, vessels of lesions. So I need to subdivide this section into three little podcast short videos because this is so huge. The first one will be melanocytic, benign and malignant lesions. The second is non-melanocytic malignant lesions, and the last one is non-melanocytic benign lesions. Let us start with the first one, but first some principle. Yeah? When I press too high on the lesions with my dermoscope, yeah, I just compress the vessels. No use. Yeah? So take care when you check the lesions, especially when they are a little bit exophytic coming out of the skin, or even they are flat. Yeah? Do not press too high. Yeah? Then you will compress the vessels. Also, a very simple trick, but when you have a make-up on one part in the face, for example, because somebody likes to hide a lesion, yeah, we cannot detect it. Yeah, just remove a little bit of some part, and we see on the right-hand side the BCC. Correct. Also, we need a little bit to know about the vessels of the scar. Yeah, when the scar is, for example, horizontal, yeah, then the vessels are going for us vertical, so just in 90 degrees around. Yeah, and after a while the scars are going to disappear. Yeah, they are going to be less pronounced after some weeks or months. Yeah, so this is normal. We need to deal with different situations. Also here, a scar after radiation, for example, angioma in the childhood. Yeah, so tricky vessels at the periphery are these vessels of the BCC. Yeah, if you doubt, yeah, take a biopsy or just check if it is a nice regular pattern. Yeah, for example, you can also take 1-2 images and check it again after 2-3 months, and you will see any difference in the BCC. Yeah, so just to have this in mind. I will not go through this, but we need to know we have different type of vessels. I will show you this in these 3 short courses, yeah, and a little bit of this different distribution of vessels, yeah. But we need to know this, but we need to go into details in the lesions, and this is important. So according to the diagnostic eye, we will start with the melanocytic lesions today. And for example, yeah, this is so typical in the dermal nevi, yeah, the epsilon vessels, yeah. So we see this here, they are not aberrizing, they stop, yeah, like the letter epsilon, and so it is nice to see. Let us start with simple, with normal vessels in normal nevi. Yeah, also very nice is the epsilon, a little bit here coming together, coming across a little bit, but this is normal. Yeah, a little bit unspecific vessels for me, some epsilon vessels here. Yeah, but this is also normal, typical for the dermal nevus. Yeah, no need to do anything. Dotted vessels are more tricky. Yeah, we see a lesions, reddish one, regular dotted vessels, but I personally, I do not like this. I always excise this. Yeah, why? I show you in a few cases. Yeah, are here dotted vessels. This is the same lesions, but what is the difference here? Yeah, here the patient was lying, so no vessels or nearly no vessels were visible, and here the patient was standing. Yeah, so we need to deal with different situations. Yeah, to think about in physics as well. Yeah. Tricky, very tricky. Fair skin, yeah, and reddish lesions, yeah, very tricky with a lot of dotted vessels. This is a challenge for all of us to deal with these lesions in these patients, yeah. And if you see one lesion which is different to the other one, yeah, I do the excision here, or at least a shave biopsy to get any result in histopathology. Young patients, yeah, 8 years old, yeah, dotted vessels in the spitz nevus. We know this, and we know when it's coming, when it's growing, and it is nodular, we should remove it. Okay. 28 years, yeah, dotted vessels, very, very small lesions, yeah. And you know this rule, before and after puberty, spits before puberty, it is most probably benign, spits after puberty excludes the spitzoid melanoma. I would excise this, so it was still benign, yeah. Atypical spitz nevus after several cryotherapies from another doctor, yeah, no histopathology, and the patient is coming. I don't know what it is. I see dotted vessels, perhaps glomerular-like vessels, but we need to excise it was an atypical spitz nevus, yeah. What does it mean, atypical, yeah? That means a histopathologist, they were thinking and debating, it is still benign or not. Dotted vessels, but at the periphery, brownish pigmentation. I always do the excision here. Dotted vessels, a little bit glomerular-like vessels in a patient 65 years old. Cut it out, yeah. A typical spitz nevus, I was happy, but not a spitzoid melanoma, yeah. Now, tricky. Dotted vessels. You would say, oh, it looks nice, similar, regular, distributed, but I do not like these dotted vessels, even they are so regular. I did the excision, severe melanocytic dysplasia. Tricky. Dotted vessels, regular, but I do not like it. Yeah, dotted vessels in such lesions, severe dysplasia. Much more easier for us to decide. We do the excision based on the peripheral of the pigmentation, a little bit atypical networks, if you would like to say, at the periphery, yeah, a little bit grayish here, yeah. It is much more easier for us to decide, yeah. And here, dotted vessels plus white lines, remember this, and eccentric hyperpigmentation, yeah. Melanoma in situ, and look how small it is, yeah, but we can detect it, and this is the challenge, and this is the importance and advantage of dermoscopy, yeah. Spitz nevus, you remember, at the back of the foot, and here's a melanoma in situ, and now you see the difference, but nevertheless, I would always recommend to do the excision, yeah. Now it's getting more and more easier for us, yeah. Eccentric hyperpigmentation, dotted vessels, yeah. This is different, yeah. We need to do the excision. Now we go a little bit further on into early stages of invasive melanoma, yeah. Polymorphic vessels. This is an alarm sign for me, yeah. Different types of vessels. I call this polymorphia, yeah. Cut it out. 0.43 millimeters, 0.6 millimeters, yeah. Dotted vessels, pigmentation, brownish a little bit. I don't know what it is. I do not like to have it, so cut it out, yeah. 0.6, yeah, 0.9 millimeters. It's getting now easier and easier, but look to the different type of vessels and white lines, yeah. Nearly 1 millimeter tumor thickness. Polymorphia of vessels, yeah. Eccentric hyperpigmentation, reddish part here, cut it out. Polymorphia, yeah, white lines, yeah, nodular, cut it out, yeah, 1.2 millimeters, yeah, just hidden here from the hairs of the belly, yeah, eccentric dotted vessels, yeah, eccentric hyperpigmentations, globular, cut it out, 1.2, also 1.2, very tricky, a little bit crust. What is it? Older patient, yeah. Here at the trunk, and I call this lightening vessels here, very faint, yeah. It was a melanoma 1.2 millimeters, yeah. This is a challenge. Here, this is the issue to detect it. Yeah, getting more and more easier. Polymorphia of vessels here, 1.3, 2 millimeters, dotted vessels, yeah. Glomerular-like vessels or lacuna-like vessels, how you want to call it, and white lines, yeah, and a hair inside, yeah. 2.5 millimeters tumor thickness, desmoplastic melanoma here in the face, yeah, polymorphia of vessels, yeah, polymorphia of vessels subangular, yeah, 2.8 millimeters, yeah, nodular, we know this, no way, but polymorphia of vessels, 3.7, 4.3 millimeters, polymorphia of vessels, yeah. You see, it's when the tumor is getting thicker and thicker, we see different types and different possibilities of vessels. 10 millimeters tumor thickness after several laser treatments outside of a GP. Yeah, what in the hell is this? Yeah, and he did it several times, and your tumor occurred and occurred again. We need histopathology, and the patients came to us, polymorphy of vessels, melanoma 10 millimeters. Dotted vessels here, eccentric hyperpigmentations, melanoma metastasis, yeah, polymorphia of vessels. I don't know, is it aberrizing vessels or not? Cut it out, yeah, but this is for me chaos, yeah. Also polymorphia of vessels here, very faint, and here lacuna-like vessels, brownish color, cut it out, melanoma metastasis. Also melanoma metastasis, globular-like vessels here, and also polymorphia of vessels with pigmentation. And we know when we see pigmentations in metastasis, it is most probably a recurrent metastasis of the melanoma. Yeah, and here also polymorphia of vessels in metastasis of the prostate cancer. So when we press too high, remember this, as I started here in the beginning, yeah, we see not really something helpful for us, but when we reduce the pressure, then we see here this typical vessels of this spider nevus. Is not a clear nevus, but this is the name of the spider nevus. That means presence of vessels which are absolutely benign. So this is the video for the vessels in the melanocytic lesions, but we have the huge universe from the other lesions, and we will see this in the next short video with non-melanocytic malignant lesions. So I'm happy to see you there soon. Bye bye.